My name is Pirooz Eghtesady. I'm here at Washington University in St. Louis, or St. Louis Children's Hospital, and I've been here for about 7 years. Specifically, I'm a pediatric cardiothoracic surgeon. My connection to the pulmonary hypertension community stems from the fact that, I say unfortunately, because that's a reality, I faced a lot of the circumstances when children have no other choice, no other option, and come to transplantation. And kind of correlated to that was this notion of, why aren't we doing the POTS shunt like they were doing in Europe when I first read about it, and was fortunate enough to have supportive partners like Dr. Grady, and essentially then it's kind of taken off in that regard. And we've seen, similar to the folks in Europe, some dramatic response. The thought process people have had, which I think is actually on the right track, is that one big distinction is in terms of when the onset of right ventricular failure or right heart failure comes about. And in patients who have the ability to shunt, to be able to push the blood in the opposite direction, the potential for maintaining heart function for a longer duration time appears to be better than patients who don't have that pop-off, if you will. When I came here, I started thinking about different ways of trying to improve the outcomes, both as bridging patients to lung transplant as well as just in general improving the outcomes. First, there was some reticence and some concern about something that you could say it is experimental, not having done it before. The very first patient was a very, very sick child that I operated on, and was basically on ECMO, and it was a patient that had prior surgery, so it was a very complex operation. Unfortunately, we got him through the surgery, and he did okay for a while, but it wasn't a long-term solution for him. We then sort of, in that process, we just kept going, and we've now done 14 or 15 patients since I started doing those about 4 years, 5 years, something along those lines. You know, it's interesting. It's been known for a long time with any lesion involving the heart that is some kind of obstruction. So whether it's an obstruction at the level of the mitral valve, obstruction of the aortic valve, obstruction tricuspid valve, obstruction of the pulmonary valve, those lesions are not well tolerated because the net effect is that they decrease your cardiac output, or they limit your cardiac output. And this is the analogy that I can give you, is that the heart is a system in series. Blood comes into the right side, goes to the lungs, comes to the left side, and gets out of the heart. And effectively, you've got 4 valves or 4 doors along that pathway. Imagine running through a corridor with 4 doors. If any one of those doors doesn't open properly, the net effective throughput is limited. And so if you have let's say a bunch of people trying to get out of a building that's on fire, wherever there is, the door is not opening effectively, you're going to get backup of people, and that room, if you will, is going to get really congested. And at first, it might be reasonably tolerated, but the more severe it gets, the more people get crammed in there. Before you know it, they're like banging the wall, breaking the windows because they need to get out. And at some point, the damage that comes becomes irreversible. So that is in contrast to when the door is absent, or when there's leakage, say, any of those valves. So that can be very well tolerated. People can go back and forth. If you have no doors, you can still get traffic, you can get flow. It's just not as effective. So when you have bad pulmonary hypertension and blood can't get through the lungs, the consequence is that the right heart starts getting unhappy and starts pushing into actually the left side, because the right heart and left heart hug each other. If you actually look at it under like sort of a cross section of a heart muscle, the right heart is kind of wrapped around the left heart. And the way those two interact with each other is like a dance. And when they contract, there is in fact a specific location where there's 3 walls, if you will. We talk about the free wall, the LV, free wall, the RV, and then the interventricular septum, which is the wall in between the right and left. Well, those interact with each other. And when the right side gets really pressurized, that septum shifts over and starts pushing into the left side. So it has 2 consequences. One is the fact that the right side is struggling, but it also starts impacting the left side. So your net effective cardiac output goes down even more so than you would expect, simply because blood's not getting around. And the ventricle, it can build up muscle, but after a time, what happens when the stress is extreme, the muscle gets replaced with scar tissue. And at that point, when you start getting scar tissue, you can't really reverse it, whether it's on the right side or it's left side. Currently, there really isn't a great way. And so, if people had a massive heart attack, historically, the reason heart attacks were so deadly was because by the time people would get blood reperfusing their heart muscle to salvage it, it would take so long, so much of the muscle would die and get replaced by scar tissue that you would be crippled from heart failure, even though things had been fixed, if you will, by restoring blood flow. Well, now because treatment is more aggressive and people get to it faster, in fact, they struggle to have trials to show efficacy of various treatments because you don't end up in that situation where you have so much of the heart muscle replaced by scar. So intervening at any point prior to development of that scar tissue is really important. Now, our ability to assess the amount of scar tissue is very limited. And the ways that we can do that are, some of them are indirect using echo and cath, but they're not super precise. With MRI, if it's really bad, you can tell. Again, you really can't assess when it's in the early phases of it. So it makes it tough. And so the notion of being able to protect the heart, protecting the right ventricle, and we have, the ways that we do it is by looking at echo and by looking at MRI to make functional measurements, is the only way we can do it. And we try to protect that, the right side, the right ventricle. And the concept of the POTS shunt is before you've sort of fallen off that curve, before that process has happened, you create a pop-off for the right ventricle so it doesn't have to push as hard at the expense of having some of blood bypassing the lungs so it doesn't get oxygen, but it allows the heart to work more effectively. You improve the overall cardiac output of the patient. So the ventricular septum no longer shifts as much, so the overall effective heart output, the cardiac output improves. Most of the patients have been here typically for about 2 to 3 weeks, somewhere in that range. Particularly when you go through a thoracotomy, it's a painful procedure in that regard and does take some time for rehabilitation. Generally, the patients have spent about 5 days in the ICU. And it kind of depends on the condition of the patient. So the patients that are coming in who are, and I know this sounds like an oxymoron, but patients who are in good shape, they do really well. If they're very sick coming in, then I think that translates into the outcome. And we had one patient who had gone to the cath lab and ended up on ECMO, and they had sent the patient to us on support, and that patient never left the ICU. So it really depends on sort of the situation of what the patient's condition is coming into the operation. But on average, I would say most patients are in the hospital for about somewhere around 2 to 3 weeks, of which maybe a week of that is in the ICU, and the rest of it is kind of rehabilitating, walking around, things like that. Please discuss it with your physician, with your pulmonary hypertension physician. It's my general impression, and this is not specifically for this procedure, but in general, that a lot of times we wait until the very end. You cannot expect good results when you have waited too long. And my overall impression, even with this relatively limited experience, that the younger the patients and the better condition they are, the better the outcome, to the point that some I've seen them be able to completely come off of therapies. It's one of those things, just being aware, gathering as much information about it. It's a very personal decision. A family has to sort of weigh the risk benefits. If they're plugged in with their pulmonary hypertension colleagues, physician colleagues that are providing guidance and are familiar with the procedure, that's great. If not, they can always, reach out. There's a number of people now that are developing expertise beyond even the surgical aspects of this. Dr. Dunbar Ivy in Colorado, we work with him very closely. And so we've had a number of his patients come through. So he has a fair amount of experience about those patients and how they do. So I think connecting with physicians like him, Dr. Grady, and various folks, I think can be an opportunity to learn more about the procedure. And certainly I'd be happy to talk to any family member who's interested, who wants to have more information about the procedure and the details of it. I think that's what I would want them to know most, that it's available, the results are promising, and sooner than later is the key. My name is Pirooz Eghtesady, and I'm aware that I'm ready.